Our next speaker is Dr. George T. From Stanford, and he's going to be talking about the GI manifestations of Parkinson's disease. Obviously, Dr. George T. well known in our community and internationally for his work with acid-base disorders, as well as Barrett's esophagus. But today talking a little bit on a different topic about Parkinson's disease. And so we look forward to hearing from him. Thank you.
Thank you very much for a kind introduction. Okay. Do you see now?
Yes.
You see this now?
Yes, we did.
Okay, great. Well, thank you for your introduction. What I'm going to try to do is, over the course of 20 minutes, give you a perspective on gut and Parkinson's disease, something that I've developed an interest in by working with movement disorders specialists. So let me start by presenting a clinical case of a 66-year-old man with Parkinson's disease who presented to the emergency room with a shortness of breath and constipation. A CAT scan was done, and you can see it on the screen. It showed severely distended colon with fecal stasis. There was no evidence of perforation. The colonoscopy was done, and we couldn't see anything. Then proceeded with a manual disimpaction that I didn't have the privilege of being involved. Multiple sodium enemas were done, and eventually, with osmotic laxatives plus Linzess and programmed defecation, the patient recovered. This is the colonoscopic view, and you can appreciate the degree of stool impaction that was 5 centimeters in diameter and moved up for about 8 centimeters from the anal canal. This is actually what prevented us to see very much and be able to do something with the instrument. A few words about Parkinson's disease. As you all know, it's a progressive neurodegenerative disease, affects about 1 million people in North America, and manifests with tremor, slow movement, and rigidity. The gastrointestinal symptoms, particularly constipation, are generally recognized, but not to the specific level that I'm going to share with you. There's also neuropsychiatric and other non-motor manifestations that you need to be aware of, although as gastroenterologists, we're not particularly involved in that aspect. It results from the loss of dopaminergic neurons and formation of alpha-synuclein-enriched Lewy bodies and Lewy neurites in the remaining neurons of the substantia nigra. More recently, what you can see here on this slide is from a recent paper from 2020. There is an appreciation of a link between the gut and Parkinson's disease, and this is a theoretical scheme of what's going on potentially, but I will show you a little bit more specific data in the next slide. The concept is that a variety of toxins alter the microbiota of the gut. There's a disruption of the epithelial barrier that leads to dysfunction, and in an ascending fashion, you have basically alpha-synuclein that goes up and deposits itself in the brain. This is an experiment that makes that link much more succinct. And what they did here is that they took albumin, lysate for Parkinson's disease patients, and alpha-synuclein fibrils. And you can see here that through the vagus nerve, then there's a ascending progression over time, not only of the Parkinson's disease lysate, but also fibrils of alpha-synuclein, but not albumin. So what happens here is you have progressive deposition on the brain of either lysates or fibrils of alpha-synuclein. So whatever happens in the gut, you may actually have a ascending progression over time of this, which end up being deposited in the brain and causes Parkinson's disease. So this is a direct experiment in animals. What I wanted to focus on is the gastrointestinal symptoms in Parkinson's disease. We have known for a long time that dysphagia is present. What we do not know, and I will show you the data, is that there's a significant impact by the Parkinson's disease of the esophageal function causing dysphagia. There's also a significant element of nausea, early satiety, and we use modern technologies to try to appreciate its magnitude. We have bloating, most of the time a result of constipation, and we also have fecal incontinence, typically a reflection of chronic constipation. Nowadays, we have a lot of tools to study the disease. We can use standardized questionnaires. We can use high-resolution esophageal manometry for esophageal dysphagia. We can use wireless capsule endoscopy or Smartpill. We can use Lactulose breath test to look at the possibility of SIBO. And we also can use high-resolution anorectal manometry to appreciate the magnitude and extent of the colonic involvement in this condition. So I will show you some data that we generated in the lab in the clinical sphere, of course, over the past probably 4 to 5 years. So starting with video fluorography, although this is not a perfect test, the best test is oropharyngeal assessment by video fluorography, but we actually start to have some data from other units about abnormalities in high-resolution manometry of the cricopharyngeus area. Esophageal manometry is used, at least in my hands, in patients with Parkinson's disease, and you can appreciate here from normal to spastic esophagus to ineffective esophageal peristalsis. So you see a variety of these conditions being present in patients with Parkinson's disease. We can use wireless motility capsule or Smartpill that allow us to assess transit time through the stomach, through the small bowel, and through the colon. And there's an example of wireless motility capsule that you see here. This is the stomach, the transit through the small intestine and through the colon. And you can appreciate the magnitude of the abnormality over time. There's Lactulose breath test that can be done to assess for possibility of small bowel bacterial overgrowth. I'm sure we're all familiar with these things. There's high resolution anorectal manometry that can be used and assesses the area of the anorectum and its communication with the distal rectum. And we can also appreciate the significance of dysphagia and its relationship to oropharyngeal events, which is obviously assessed by video fluorography, as well as esophageal dysphagia, which can be best appreciated by high-resolution manometry. How do we assess bloating and distension? That combination of symptoms usually manifests as a reflection of underlying gastroparesis, small bowel bacterial overgrowth, or constipation. And again, the tools used here are wireless motility capsule, combination of that, as well as Lactulose breath test, or wireless motility capsule for constipation. It is important to assess the possibility of other disorders that cause constipation, such as drug-induced, and this is particularly true for patients with Parkinson's disease who take drugs for their neurologic disorders that are having their own effect on constipation. There's neurologic, such as Parkinson's disease, of course, metabolic reasons, such as hypothyroidism, for example, and there's obviously mechanical obstruction, which, as I showed you an example, from a fecal impaction or other conditions such as cancer, etc., that one needs to assess before ascribing the constipation to the Parkinson's disease. So again, to emphasize the tools that we have for the appreciation of the magnitude and severity of constipation, slow transit constipation is assessed best with the Smartpill. Defecatory dyssynergia or outlet obstruction can be appreciated by high-resolution manometry, and overlap syndromes where both abnormalities can be present. Let's start with the esophagus first and clarify a few points. I'm showing you some endoscopic examples. Candida esophagitis can happen in the context of patients with Parkinson's disease, as you can see on the left, usually reflecting an underlying dysmotility. Meat bolus impaction can happen, simulating sometimes achalasia, and spasticity can happen in some patients with Parkinson's disease, simulating diffuse esophageal spasm. When we studied 95 patients with Parkinson's disease, we excluded many of them because they did not have high-resolution manometry, but in those who did, were 33 in number, 31 of those 33 had abnormal esophageal manometry using a high-resolution esophageal manometry. If you look at the symptom prevalence in these patients, obviously the majority of them have dysphagia. Some of them had odynophagia. Some of them presented with heartburn and regurgitation. Some of them had chest pain. And a lot of them had weight loss as a reflection of their dysphagia. So they do have troubles from the esophageal abnormality involved in patients with Parkinson's disease. In terms of severity, the majority of patients had trouble, significant troubles with dysphagia. And again, weight loss was a prominent feature in that patient population. If one looks at the prevalence of motility abnormalities based on high-resolution esophageal manometry, you can see that a fair number of them have ineffective esophageal motility. Diffuse esophageal spasm was present, fragmented peristalsis, and esophagogastric junction outlet obstruction, and very few patients had normal esophageal manometry. And these are some examples that I'm not going to bore you with, but you can actually see a range of these abnormalities in the patient population with Parkinson's disease. So do not hesitate to ask for an assessment by high-resolution esophageal manometry. You will be surprised how many times you will see these abnormalities being present. Traditionally, when I was in training, we didn't really have a clue about all these things. We didn't even think about assessing the esophagus. We always attributed dysphagia in these patients to oropharyngeal abnormalities. Another thing we did in response to that initial cohort assessment is we actually did a long-term evaluation in something that we call natural history study in patients with Parkinson's disease. And we invited them back to have not only a retest assessment at 1 month, but we also looked at them up to 3 years to find out if there are any abnormalities. And I will show you some of that data. But basically, as you can see here, at 1 month after the initial high-resolution manometry, there was no significant change. Oops. There we go. And what you see here is the prevalence over time. For the majority of the patients, we did not see any dramatic changes, although some patients did have some alterations over time. Unfortunately, with this patient population, we did not have the ability to keep them coming over the course of 3 years because they are affected by the disease in terms of their natural history. Some of them pass away. Some of them do not like to come back for another manometry. So we lost a significant number of patients, a few patients who could not be studied over time. But you can appreciate some differences over time with a significant reduction of abnormalities, but this is basically a reflection mostly of the lower number of patients we studied at 3 years. And we could not really reach statistical significance. The next step that I would like to discuss is the stomach and the small bowel as a manifestation of, as an expression of abnormality of Parkinson's disease. And I wanted to share a patient who presented with bloating, postprandial fullness, and constipation. And on this CT scan, you're going to very quickly appreciate the gastric stasis as well as the colonic stasis. And sometimes you may have stasis everywhere: esophagus, stomach, and small bowel and colon. So be prepared for significant abnormalities along the entire length of the gut. If one looks at the prevalence of gastrointestinal symptoms in Parkinson's disease, you can see here that bloating and constipation are the leading symptoms that you can appreciate by seeing the patient's weight loss in about 60% of patients, abdominal pain, usually manifestation of constipation, as well as fecal incontinence, usually again as a manifestation of fecal impaction with overflowing incontinence. How do we evaluate patients with bloating? We studied a fair number of them by doing a gastric emptying scan, small bowel bacteria, small bowel transit times, as well as lactulose breath test. And you can see here, many patients were studied in all 3 modalities. And one looks at the symptom severity, the majority of patients complain mostly of bloating, which is the leading symptoms, with a variety of other symptoms that are somehow reaching some degree of magnitude, but not that dramatic. Vomiting is not particularly common. Belching, weight loss, pain, and regurgitation can be seen, but not to the degree of magnitude that we see the symptom of bloating. If one looks at abnormal transit in patients with Parkinson's disease, 60% of patients have abnormal gastric emptying time. 40% of them have small bowel transit time increase, and a fair number, 70%, have colon transit time increase. If you look at the magnitude of these abnormalities, with normal and gastric emptying transit being less than 4, the magnitude was about 7. With normal being less than 6 hours and the small bowel transit, it was 8. And the most significant change is, again, the colonic transit time, with normal being less than 59 hours, being on the average or mean transit time of about 77%, 77 hours. If one looks at the prevalence of these abnormalities, gastric emptying time was significant, almost 50%, small bowel transit time, 20%, and lactulose breath test in about 30%. The magnitude of these abnormalities, you can see abnormal gastric emptying time of about 12 hours, with normal being less than 4, and abnormal small bowel transit time of about 10, with normal being about 4 to 5. And if you can appreciate the changes over the next month, actually in this case is over time of the 3 years, you can see that about 10% change over time, over the course of about 2.5 years. What kind of tools do we have to improve the presentation and the outcomes? This is an example of the use of BoTox injection in the pylorus as treatment of gastroparesis. I've had great results with this. This is, again, as you can imagine, a compromised patient population, and the BoTox injection is not particularly dangerous to do, and it's quite effective. I actually have patients now who come almost every 8 to 12 months on a yearly basis, if you will, that they come for a repeat evaluation and retreatment with BoTox. And that actually is a significant improvement for their quality of life without significant risks. If you look at small intestinal transit time over time, basically there are changes, but not significant changes over time. So that is not a dramatic change. If one looks at the baseline of lactulose breath tests in patients with Parkinson's disease, about a third of these patients have abnormal results. 70% do not. But that 30% of patients that you see here in red actually is quite important, because the minute that we treat them, typically with Xifaxan, they have a significant, very significant neurologic improvement, to the point that the neurologist, without knowing what I did, they would call me, something happened, and this patient is dramatically better. So one of the easy things to do, either an empiric trial with Xifaxan or a lactulose breath test, and then treat accordingly. How about the colon and anorectum as we go down the gut? Things that can happen in this patient population, either acutely or slowly over time, is obviously fecal impaction that you saw an example, or air fluid levels that present when these people come to the emergency room. So again, keep in mind that when you see these kinds of manifestations, you have to take some action, typically by excessive laxation or the use of enemas from below. These are some examples of acute presentations. And what you see there is a colonic volvulus that requires surgery. These patients do present with very impressive symptoms that you need to be aware, because you may actually have to intervene colonoscopically, as you see in the middle picture. So when we studied a patient population with Parkinson's disease, in this case 66 patients, we found that almost 90% of them had abnormal high-resolution anorectal manometry, 60% had abnormal wireless motility capsule testing, and about 60% had a combination of abnormalities seen in both these tests. So be prepared to have some kind of an assessment that will help you hopefully design a management plan for these patients who have chronic disease. The other thing that you need to be aware of, if you make all these decisions, to basically consult with a neurologist, because these patients change medicines a lot for their Parkinson's disease, and you need to make sure that you are aware of these changes. It's almost impossible to take these patients from a particular drug to another or to nothing, because they develop quickly Parkinson's disease manifestations And that actually may change your decision-making over time. The symptom severity, as you can see here, is quite significant in terms of straining, constipation, and incomplete evacuation, and significant degree of bloating. So these are the symptoms to look for as you manage these patients. The magnitude obviously is quite significant. Again, the colonic transit time is about less than 60 hours. Here you go up to about 80 hours, and very few patients have normal colonic transit time. And if you look at, again, over time, things may change to a degree. And you can see actually over time of about 2.5 years and 2.5 years of observation, we saw some changes of this degree, which is not very significant. Another possibility here is that you may encounter patients with Parkinson's disease with Ogilvie syndrome. And that actually happens not infrequently in the hospital setting, to the point that actually when they call you for a consultation about what to do about these patients, one of the first things that you ask is to what degree they carry the diagnosis. There's a gastroenterologist actually making the diagnosis of Parkinson's disease while the hospital team has not appreciated that. And then you initiate a referral to neurology to eventually prove the diagnosis after the gastroenterological diagnosis has been made. A high-resolution anal manometry is also a tool to assess these patients, and that field has changed significantly. I'm not going to bore you with these changes, but there are different classifications in the past. Recently, about this year, there was a new classification that I'm going to try to introduce you to, but what matters is for you to make the recognition that there are changes that you need to appreciate on high-resolution anal manometry. So these are the different type of dyssynergia. This is the all classification, depending on how well or not the rectum propulses and how well or not the anal contracts or relaxes. And these are the different manifestations that you see here. Using the all classification, typically you see a significant range of abnormalities that you, depending on their findings, you may decide to act accordingly. An important thing here in this slide is the fact that 88% of patients have abnormal balloon extraction. A significant percentage of patients have dysfunction at the internal and external anal sphincters. The sensation is generally normal, and the rectoanal inhibitory reflex is absent in about 20%. So that's another clue to the underlying presence of Parkinson's disease as neurodegenerative disorder. This is a new classification that assesses these four elements that I will show you some data, but I don't want to really confuse you in terms of what's going on with these patients. But it's nevertheless an important thing to do as you assess these patients using this classification. And what you see here, again, we did this test-retest in 1 month. We did not see very significant changes. Again, the prominent feature here is the balloon extraction test that was abnormal in 70 to 86% of patients. And you can see here again, this is a baseline and follow-up period of time up to 3 years. You can see here again, very similar abnormalities because the number of patients could not reach a significant number to do statistical calculations. The only thing that really stood up was the abnormality in balloon expulsion. To conclude, as far as the high-resolution high-resolution anorectal manometry, using the classification that's recently introduced, you may have findings such as worsening areflexia, loss of hypertonicity, worsening hypotonicity and hypocontractility, worsening hyposensitivity, enhanced hypersensitivity, and worse balloon expulsion. These are all at this point not reaching statistical significance, but these are observations that you can see as you study these patients over time. And again, to emphasize this, these could reflect alterations in the underlying treatment of Parkinson's disease because the drugs for this condition may have their own separate side effect, manifesting as these colonic abnormalities. And again, the BoTox is very useful, particularly in patients with high anal pressures and poor relaxation. And I have done it several times with good results. And here you see a BoTox used in different locations, for example, in the esophagus, depending on the finding, either at the level of the gastroesophageal junction or at the level of the distal esophagus. The pylorus that is useful for people who have gastroparesis, and the anal canal in some patients. These are just patients that I had started with exploring the role of BoTox, and I found it actually over time in more patients than what you see here quite useful. So to address the therapeutic implications and close on my talk, in general, the manometry of the esophagus helps to define the management of dysphagia and guide therapeutic intervention. We see a fair number of patients who have gastroparesis and contributes to bloating and weight loss. But importantly, I would like to emphasize here, it may actually contribute to poor drug efficacy because the absorption of the Parkinson's medications is not very good. And some patients end up having the need for a delivery of the Parkinson's drugs into the duodenum, something that's called duopa therapy. Sometimes lactulose breath test detects SIBO, and the treatment of that SIBO actually may have a positive effect in the neurologic presentation. I usually recommend the use of wireless motility capsule as a valuable clinical tool, since it may highlight unsuspected abnormalities that may then be treated accordingly. The majority of Parkinson's patients have overlapped constipation and will need to have therapy for both defecatory dyssynergia as well as colonic inertia with a variety of drugs. In general, I also have found, although I'm not showing you the data, that fiber is not well tolerated with patients with colonic inertia and is not particularly likely to be effective in patients with Parkinson's disease. They tend to basically keep accumulating fecal contents, including fiber, in their colon, which progressively becomes distended. Since rectal sensation is frequently preserved, bulking with fiber aimed at improving rectal sensation may not be needed. Physical therapy should be tried with in patients with defecatory dyssynergia, but its efficacy is unclear. Osmotic laxatives such as linaclotide and lubiprostone could be useful in the treatment of colonic inertia in patients with Parkinson's disease because they tend to shorten the colonic transit time. Since many patients with Parkinson's and constipation have low anal pressure profiles, the occurrence of fecal incontinence may be limiting. So it's a struggle to find the right regimen for their constipation because they typically have overload incontinence. And sometimes I used actually large amounts of laxatives, particularly, let's say, golightly once every other week or so to empty completely the colonic contents and start over. Some of these patients may actually need programmed defecation to empty the rectum so that you can avoid significant issues with both constipation, fecal impaction, as well as fecal incontinence. And BoTox therapy may be useful in some patients with Parkinson's disease who have dysphagia, bloating, or constipation. Thank you very much for your attention.
Thank you, George, for a very informative talk. I think we have time for just a couple questions. One question that I had is, oftentimes constipation seems to be the first symptom that patients with Parkinson's develop, or at least the kind of most bothersome symptom. Is there any data to show that constipation is often the first symptom that these patients develop before clinically significant neurological symptoms?
Absolutely. This is actually very key, and I'm glad you brought up the issue because of the fact that some people actually may develop constipation up to 10 years before Parkinson's presents. And there's actually a group of patients who have family history of a parent or a relative with Parkinson's disease. And if you study them upon the discovery of constipation, when it presents for the first time, you can actually find early neurologic features and follow them up over time to then identify them as having full-blown syndrome. So it is actually a very, very important issue for us as gastroenterologists to actually keep that in mind and detect patients who would actually benefit from early recognition and early management of the disease.
Thank you. And maybe one last question. As you showed, these patients with Parkinson's often have global dysmotility, where they have ineffective esophageal motility, gastroparesis, as well as slow transit constipation. In these patients, especially if they've had wireless motility capsule testing, do you recommend, rather than trying osmotic laxatives, something like prucalopride or even Mestinon, which might address their global dysmotility?
Yes. So depending on the presence of an abnormality, let's say stomach, small bowel, colon, I usually basically try to treat them according to their localization of the disease. But frequently, as you heard, the localization is generalized panmotility. Under those circumstances, prucalopride and or Mestinon are used. At least I use them, trying to improve their function. Reglan, actually, I also use Reglan, which is not theoretically a good idea in this patient population. You may actually try to see how well they do in patients who have gastroparesis as an isolated feature. Depending on how the doses that you use and how they respond, you may even use that. But in general, I find these drugs something that we can try. BoTox is harmless, and you can try it in either the stomach or the anal canal, depending on the abnormality. So yes, the usefulness of the wireless motility capsule is that with one step, you actually have three answers very easily. So I don't really bother, if I can, doing gastric emptying scans, because I have the ability to test with one study all three possibilities. So to me, that's actually a very significant help. But sometimes they don't get authorized, and that's a problem. Typically, in this patient population, we have Medicare patients, and Medicare does not give us difficulties in terms of approving the use of the wireless motility capsule.
Do you ever forgo Smartpill, especially in someone with frequent impaction? Mainly because it's a hard test for the patient. They have to avoid laxatives for a week before often, and then they're not on any laxatives for the week of the test, and 2 weeks without any treatment is sometimes a miserable 2 weeks for the patient. So in someone with recurrent impaction, do you ever just forgo that, or is it still useful?
Yes, I do. And sometimes because of the oropharyngeal elements, they cannot take the test. They hate me for that. It's not an easy test. So beyond all the other insurance logistics, it's a hard test for them because of the logistics that you just mentioned. In other words, you have to stop the drugs for constipation and so forth and so on. So it is actually something that I do upon agreement with the patient that we may not be able to do the test. I have tried the SITS marks. I have tried gastric emptying scan in lieu of the wireless motility capsule. The majority of the patients, I would say probably 80%, can tolerate it. But for the natural history study that I showed you some data, a lot of these people hated to do the test because of all the logistics. So that's a reality for these patients. It's also a reality that I never try to stop their drugs. I ask the neurologist to try to manipulate the drugs and see if they find any improvement without my intervention by doing testing, because obviously that has easy advantages as well.
Well, thank you again, George, for a very informative talk, and we appreciate your time on this nice weekend.
Thank you. Thank you very much.